Okay, good afternoon to everybody. My name is Antonio Colombo from Milano, Italy, and it is my pleasure to introduce this symposium sponsored by Med Alliance regarding modern usage of drug-coated balloon. I'm not going to spend time to go over the objective because I think the objective is to learn how to use these devices besides in-stent restenosis. I encourage people to ask a question, to send a question. They will be recorded and we try to answer most of them. Dr. Kambis Mashayekhi is going to be the first speaker and is going to illustrate the characteristic of this specific sirolimus-eluting drug-coated balloon.
So thank you very much, Antonio. So we just go through the most important thing that you get an understanding about what we're talking today. So those are the conflict of interests. So there's quite a progress in coronary vascularization over years, starting by bypass graft 60 years ago, now ending up with second generation of drug-eluting stent. And then the first generation of drug-eluting balloon came up. You know the story of the BVS as well. At the moment, we don't have a good guideline recommendation for that. Now we're focusing more and more on a second generation of drug-eluting balloon with special sustained limus release. So the point is here that we still have, if you look at this landmark analysis, it's a meta-analysis of 19 trials, that we still have a high event rate once we deal with stents. Means more than 2% per year target vessel failure, no matter which stent you implant. And still, if you look at long-term outcomes, which means 10 years here, you see that there's a really high event rate, 3.3% event rate every year. And this is also a cumulative incidence of the primary endpoint, which is MACE, target vessel failure, and death, MI. So you see up to 10 years, still 43%, no matter which drug you use. Well, there is a new paradigm for metal-free PCI, and we are concentrating more and more on that, especially if we have lung disease and diffuse lesions, as we see it more and more often, also in diabetic patient with chronic total occlusion as well. And the idea behind this is that we preserve arterial physiology, we allow a positive remodeling of the vessel, and we try to avoid metallic scaffold complication, we have shorter DAP, and we keep up opportunities for the future procedures as well. So now to the product of the session, the solution SLR. So the special thing here is that you have micro reservoirs, and there is a sustained therapeutic effect for up to 90 days, which is quite interesting. And then you have a proprietary microreservoir technology and a cell arterial technology. And just look at the video here that you better understand how the product is built up, this new drug-eluting balloon. And yeah, here you can see the microreservoirs as well. And then the drug is delivered through the vessel wall, as you can see here. So I will go a little bit into the details of the restenosis cascade. As you know, the first, what we want to avoid is acute thrombosis, and then inflammation. And then there is a period where we have the smooth muscle cell proliferation. And when you look here at this green bar, what you see is that the solution, SLR, still gives the drug to the vessel in a sustained release over 90 days. And this is quite important compared to other products, right? It's behaving actually like a drug-eluting stent with abdominal stent generation compared to other drug-coated balloons. And another interesting thing is that there is quite, even as we know from all those drug-eluting balloons in the past, that we have a loss of drug during the procedure. And this is a benchmark test from Medalines itself, was done from peripheral balloons. And what you can see here is that the loss during the procedure is quite high in the other balloons, up to 80%, and compared to the solution with 36%. It's quite interesting. So nevertheless, we have to improve superiority also regarding endpoints, and this is why the solution de novo study started. It's a big randomized trial, over 3,300 patients, and it's a trial where drug-eluting balloon versus drug-eluting stent are compared regarding it's a strategy trial, and it's still already enrolling. As you can see here, the primary endpoint is target vessel failure based on non-inferiority at 1 year and superiority at 5 years. And there's a one-to-one randomization, and you can see all the B strategy, all the E strategy. Nevertheless, there's around 30% allowed to go crossover once you do balloon-based strategy might end up in dissection or let's say slow flow or something like that, huge dissections or limited flow, then you might be allowed as well to cross over. At the moment, what I heard is that there might be around 15% crossover in the study, but it's not official data yet. Thank you very much.
Thank you. Thank you very much. We have 4 minutes for discussion, so if any question from the panelists, from the audience.
So may I ask Kambis, you know this drug-coated balloon, obviously, so how is it different from other products available on the market in terms of drug release, and how is that pharmacokinetically helpful for preventing the stenosis?
Well, you've seen the slides, right? There is a sustained release up to 90 days, which is very important to avoid instant restenosis. And another thing is that we didn't focus on is that the particles are very, very small. What we've seen is, especially also in other trials or other balloons, that there might be some flow limitation based on very big particles with microembolization. We don't see that so often, so there might be a superiority as well regarding the new design of the balloon.
So may I ask one question for the panelists? I would like to ask your opinion about the using of the drug-coated balloon in the vein grafts in stenosis.
Probably
is it possible, or is it promising, or just?
No, I personally only used in my experience a drug-coated balloon when I had in-stent restenosis located in a vein graft. Usually, to tell you the truth, in the last 3 years I treated maybe 2 or 3 vein grafts.
Yeah, that's true that most of the time we go for the native vessels because of the risk of embolization, I suppose. But who knows, maybe it's also a promising way to treat the vein grafts.
No, but I think to seriously answer your question, I've no data to answer your question in a reliable fashion.
Maybe I can comment on the vein graft. I think there's a role for distal anastomosis because there's a lot of size mismatch in your vein graft and your native vessel. So I think, drug-coated balloon is maybe a good therapeutic option for the distal anastomosis.
It's drug lost on the coated balloon during the transit. Have you any comparison with other products like Sequent Please or Magic Touch?
Well, what we know actually now from the company standpoint is that there are only these two other balloons tested, right, on the bench. So I don't have information from other data. Yeah.
I was just coming back on the question about vein graft intervention. We've got an enormous database of DCB work, and our conclusion is that for de novo vein graft work, DCBs come out with a MACE rate that's very similar to drug-eluting stents. And actually the answer is we shouldn't really be doing angioplasty in vein grafts, we should be fixing the natives. Exactly. Generally.
Okay.
Yeah.
And I think that most people would still try to do that, wouldn't they, even if it's a CTO.
Yeah.
Okay. So if there are no other, I'm sure the question will come along the presentation of the cases. There will be a series of case presentations, and the first presenter is Dr. Hee Hwa, who is going to discuss a case of, I hope, diffuse disease or long lesions.
Okay. Thank you very much for your introduction, Dr. Colombo. So my name is Hee Hwa from Singapore, and I've been tasked to share a case on a patient with long diffuse disease and why you should think before you stent. These are my disclosures. So the patient is a male, 63 years old, ex-smoker with multiple cardiovascular risk factors. So he had prior PCI to LAD back in 2015 with 2 long drug-eluting stents. So he had long-standing diabetes mellitus on requiring insulin for control, and he presented to our hospital with NSTEMI in January 2022. From the ECG, you can see that it is there's no acute ischemic change, so we can't really tell which is the culprit artery. So if you look on the picture on the left, you can see that he has a severe stenosis in the mid to distal left circumflex, but this is a rather small vessel. And the stent is widely patent in the LAD. We come to the right, a little bit of plaque, minor plaque in the proximal RCA. And you can see that he has quite a large RPL and RPDA. There's severe critical stenosis in the proximal segment and the middle segment of the RPDA. From the RAO shot, you can appreciate how long the RPDA is. So looking back at the old angiogram, comparing, you can clearly see that the RPDA has progressed significantly. So we thought that the culprit artery would be the RPDA, and this should be our targeted vessel for PCI. So the question that we would like to ask ourselves is, how should you treat a patient with long diffuse disease with underlying diabetes? So maybe I can open for discussion.
So probably we ask our ladies in the panel how they would treat.
Yeah, so we have a rather young patient, 60 years old, diabetic, and distal vessel. We don't want to implant too much metal in small vessels. We know that these patients are prone to restenosis, and I think this would be a very nice lesion for DCB to try to leave the vessel as it is without any metal, to avoid stent-related complication afterwards, to allow the vessel to remodel, to retain its vascular function, vasomotion. And so I think this would be the ideal candidate for DCB and short listing.
But, in real life, I mean, we are DCB aficionados here, but in the real world, I would say the large majority of interventionists will have no fear to implant a 2.5 38 millimeters DS in this vessel.
Well, the problem is what you do later, because
but
keeping it open is
you
the
don't
issue.
have to convince me. You have to convince. But this will be the standard approach. Yeah. I mean, in many labs, when I walk in, I see 38 225 DS, and I get perplexed.
Yeah, I mean, to begin with, this is not a 38 millimeter lesion. I think in diabetic, you still need to spot stent and avoid full metal jackets. Because indeed you end up with a high risk of instant restenosis. And as you rightly pointed out, this is a young patient who will probably come back in the future. So preserving the distal targets, whatever they may be for the surgeon in the future, is also not unimportant.
Yeah, there's one question.
As we can see, we had actually good result on LAD 7 years after previous PCI. So why not put standard?
Yeah. This is a very important remark. It's not easy to give you a contradictory statement. And maybe those stents were not implanted with state of the art. If you implant these stents with IVUS and OCT, who knows? But that's the reason why we need data. I mean, it's nice to be enthusiastic, but we know that science is not always pleasing the enthusiastic people.
There's another question in the back.
I'm just I would like to say my opinion. Maybe it's a comment. First of all, we need to overcome from the anatomy of the right coronary artery. So the PDA branch is maybe 2.5, and the distal part up to the bifurcation is more than 3.540. So if we will do anyway the crossover stenting, because this osteo lesion, so we can make some malposition, because 2.5 dilating up to the 4.0, it's maybe impossible, but the one chance just to make a DCB in this point.
Okay, I think we need to continue. Let's see what you did.
Okay, thank you very much for the comments. I'm going to show you how did I treat. So I think if we opt for stenting, I think we're going to be stent very long, perhaps going to be 60 mm or more. So I think the study from Korea has shown that if you put in long stents, it is associated with TRR, as well as increased risk of cardiac death and stent thrombosis. So my option at that time, or my choice, was to use a drug-coated balloon. As we have heard, it has several advantages. You treat the disease segment and you with local drug delivery, and you leave no permanent metallic frame. And the fact that you have no stent, there's no risk of stent thrombosis, and there's always this potential for positive vessel remodeling. So with DCB, I think the important thing is to do an optimal lesion preparation. So you need to pre-dilate the lesion with a semi-compliant balloon. You can use a specialized balloon like the scoring balloon. For very calcified lesions, you can consider a rotablation or lithotripsy. And if you get a good angiographic result, residual stenosis 30% or less with non-flow limiting dissection, then you can finish your procedure with drug-coated balloon. So I wired with a Sion black guide wire and used a 1.5/15 to predilate the proximal segment, followed by a 2.0. And you can see that still not very good. This proximal segment is still looking not very good. So I went back with a Scorflex 225/15 at high pressure to prep the lesion a little bit better. And you can see that I got quite a good lumen gain. So this is quite a diffuse small vessel. And as we have heard from the basket small 2, this is the largest RCT on small vessels. The use of DCB was non-inferior to DS up to 12 months, and the results is sustained up to 3 years. A very important sub-study for the basket small 2 is focusing on the diabetics. So what they found is that in patients with diabetes, if you use a DCB, the need for TVR is a lot lower when compared to a drug-eluting stent. So a good therapeutic option for my patient would be to use the solution sirolimus DCB. As we have heard, it is using sirolimus, and the drug is released up to 90 days, and it has its unique CAT technology. So for the mid part of the RPDA, I use a solution 225/25. One feature of the balloon that I really like, it is very deliverable. And for the proximal segment, I use a 25/30. And that was the final result, which I thought was quite acceptable. So one of the things that when we do DCB angioplasty is we worry about acute closure. So patient had a chest pain a few hours later with a bit of EKG change. We brought him back to the cath lab to have a relook. And you can see that the RPDA was widely patent. So I think if you do a good angiographic final result with no low flow limiting dissection, the risk of acute closure is actually very low. And patient is clinically well on follow-up. So my take-home message is DCB angioplasty is safe and feasible in long diffuse CAD, as shown in my case. It's important to do the lesion preparation. You need to be a bit patient and do it well. Important to know your dissection grade, knowing which lesion that you can leave alone and which one will require bailout stenting. So the beauty of DCB angioplasty is you are converting severe CAD into minor CAD and you leave nothing behind. Thank you very much for your kind attention.
Thank you. Thank you very much. We go to another case. It is the case of bifurcation lesion. And Dr. Sudhir Rathore will present this case. And we go the same presentation. We give a break on how we treat and then the treatment.
Thank you, Antonio. So I will be presenting, so continuing on the same theme, I will be presenting a complex bifurcation case. So I've got no conflict of interest to declare. So my case is a 74-year-old gentleman, male, who presented with severe chest pain for last couple of hours, and he was brought to our accident and emergency department with no previous history of known coronary artery disease. The background of smoker, he's a hypertensive, hyperlipidemia. He's had previous CVA 10 years back and previous carotid artery stenosis. So his ECG, I will show you, showed inferolateral ST depression with some ST elevation in the AVR lead. So he was obviously treated, considered as a primary PCI. So he was loaded with ticagrelor, 180 milligram and aspirin 300 milligram in the accident emergency department, and was primary PCI was activated. So I'll just show you the ECG. This was the ECG for this gentleman. So you can see there's a widespread inferolateral ST depression. There's some ST elevation in AVR lead. So he was brought to cath lab after preloading. So 3 hours history of chest pain. And this is his coronary angiogram. This is the right coronary artery. You can see the dominant vessel, got a diffuse plaque disease, but nothing looks significant. Then this was his left coronary angiogram. As you can see, he's got a severe left main stem lesion, but what you can't appreciate here is that he's got a bifurcation, which the left circumflex coronary artery is originating very acutely, like parallel to the LAD, and then it turns at 90 degrees. So the angle of origin is very short. So we have to use, put the wire in to just find out what's happening. So basically he had a left main lesion, which extends into the proximal LAD and the proximal left circumflex coronary artery, which is a decent sized vessel. And I'll just stop here to discuss how we will proceed with this case. This was my discussion points for this case.
Okay. Maybe can you, while we discuss, can you just put on the screen the angiogram so people make it run?
First one.
Okay. So any...
Now, this, because it was a STEMI situation, so there's no imaging available for this case, but it was clear to us that it is a severe left main extending into the proximal LAD and proximal circumflex. There's further disease you can see after the large diagonal bifurcation, as well in the mid left anterior descending coronary artery, which is diffusely diseased up to the distal segment.
Okay, so I think no debate is about treatment of the left main with a stent. I think at this point, would you all agree that
No,
I think
absolutely. You need one stent, but you don't need more than that to help.
So how would you treat besides the stenting of the left main that most of us agree? I see disease of the proximal circumflex is, this patient would be easily enrolled in a randomized study of 2 stents versus 1 stent. And as a matter of fact, the guidelines don't contradict using DK crash in the circumflex, which despite the love for DK crash I have, I will try not to use it. And then there is a long diffuse disease in the mid-LAD, I suspect that if you put a pressure wire there after having treated the left main, because you need to treat the left main first, I would not be surprised if the FFR is abnormal.
Do you think there is also, let's say, rationality to just treat the left main, stent left main LAD, kiss to the circ, and then bring the patient back again with physiological assessment?
Absolutely. I think stenting the left main, to optimize the left main stenting, do kissing, maybe not super aggressive kissing on the circumflex in order to avoid dissection. And if you have, I don't want to take away what you did. So maybe...
I think the other reason
who would put a stent as intention to treat on the circumflex?
Okay.
Well, we are not following the guidelines.
No, but I think... don't you think that the reason...
No, definitely not.
Do you think that the reason to avoid the circumflex stenting would be that this is also an acute coronary syndrome, which in this context has a more prothrombotic milieu?
Not necessarily. If you do two stents well, they don't thrombose if you do a good job. But the fact that they don't thrombose doesn't mean that they don't restenose. And you see the movement of the circumflex in the in the LAO caudal. And I think that movement is a kind of antagonistic to stenting.
Agree. It might be even stent fracture predisposing restenosis and the ostium of the...
Because the restenosis on the ostium of the circumflex is the only way to avoid the restenosis on the ostium of the circumflex, I always tell, is not to do follow-up angiogram.
Well, the problem is that sometimes the patient comes with chest pain, right? And then you have to do an angiogram.
But you have to select the appropriate projection.
Oh, yeah,
we have checked the biomarker. You think is important to check also the biomarker in these patients?
Yes, we will. We've checked the biomarker, but this patient was brought in as a hot case, urgent, so the biomarkers were not available when he came to the lab. But there was no doubt it is acute coronary syndrome, and it's a thrombotic lesion. So biomarkers are important as well. So we checked, but it was not available at the time of the procedure. I don't know how that will affect the strategy decision making.
But with this acute setup and ST elevation in AVR, I think the simple thing will be to put a stent in the left main to LAD and then pot, and definitely provisional strategy is the best one because circumflex lesion, osteal lesion also not very long. But what is a long osteal circumflex lesion? Nobody knows. 5 millimeters. So yesterday somebody said 7 millimeter. So probably in acute setting, it will be a single stent strategy.
Yeah. And I think we all agree that in such a setting, we want to keep the procedure simple or as simple as possible and as safe as possible. And I think everyone would go for a provisional strategy, leaving the options open to what we do then, instead of going up front with a stent.
There's one comment as well from
combination like stent in the main vessel and DCB in the side range.
I think this was done. You go continue.
You stole the punchline.
Right, so I think those are the options came to mind. Whether obviously the strategy, as Antonio mentioned. So I'll just share. So how did I treat? So all those options come to your mind when you got a left main bifurcation lesion, whether you adopt a provisional strategy or two-stent strategy upstream. Now, the provisional strategy doesn't mean that you can't put a two-stent strategy, but you have to do a crossover stenting. So what I did, so we went through right radial artery. We used a 7 French guiding catheter, a slender sheath, EBU 3.5 with wire in both arteries. And we aimed for a provisional left main crossover stent into the LAD and then see how the side branch looks like. So we dilated with 3.550 non-compliant balloon. And you can see the balloon is fully inflated. And then we took a stent, which was 3.5 by 22, resolute onyx. We inserted crossover from left main ostium into the proximal LAD into a good landing zone, followed by proximal optimization by a 4.5 by 8 non-compliant balloon, which is done here. And now the question comes, obviously, if you see, this is the result after that. So that is where the strategy has to be clear, because there was definitely, because of the sharp acute angle into the circumflex and not clear how much length is involved. So at this point, either you can leave it as it is, the circumflex, it is TIMI 3 flow, residual stenosis is significant and it's extending few millimeters into the circumflex, or should we do anything about the side branch? Now, being a large side branch, from the experience, our experience, and from the historical experience from the randomized trials, if we leave them significant stenosis in the side branch, there is a high, obviously TLR rate, means the symptomatic restenosis and symptoms are high. So as most of you suggested, we recrossed into the side branch, as you can see here. And then what we did is here, so we recrossed into the distal stent strut into the side branch, and then we opened up the side branch strut with a 2O semi-compliant balloon and made sure that the 2O semi-compliant balloon at the lowest possible pressure is fully dilated with no residual stenosis on the side branch. So I think the lesion preparation is very important, and you don't want to dilate very aggressively to cause dissection in the side branch if you want to not put second stent here. And followed by, I treated the side branch with a 2.75 by 15 a solution SLR DCB at 6 atmospheric pressure when it's fully inflated for 60 seconds, and followed by kissing balloon inflation. Now I used the same balloon in the side branch to use as one of the balloons, and then took 3.5 by 15 non-compliant balloon for left main stem into LAD, and we did a kissing balloon. And this was the procedure done here. And this was the post-angiogram. And then we did the report as suggested by the bifurcation community. We used a 5.0 by 8 millimeter non-compliant balloon in the left main stem to do the report to make it more aligned. As you can see, so this achieved a pretty good result for us in both LAD and both the left main stem LAD and the side branch. And then, as Antonio suggested, we did a FFR to assess the lesion in the mid LAD. We were planning we will do the pressure wire now and bring back the patient if mid LAD needs to be treated. But this was non-flow limiting. There was no significant, as most of the people say that you do after. So how do you assess the result of kissing balloon angioplasty without a second stent? If there's no residual significant stenosis, TIMI flow is good, and there's no flow limiting dissection, then you are good to go. And we have treated this with GP2B3 inhibitor as well. And this was the final result of the patient. And then this was the ECG 1 day post procedure, and the patient went home a couple of days later. So this was my procedure. Now, this procedure will look exactly the similar if I have not used a drug-coated balloon. If I've just done the just a non-compliant balloon to the side branch kissing balloon. But the proof of the pudding is in the eating. So I sometimes bring this patient back after a few months to see how the side branch lesion is doing. It's not clinically related, but the patient came back for further assessment. We're more interested in the LAD. So we've got a angiogram to share, which we did in 6 months' time, follow-up angiogram. So the result is still holding. As you can see, the side branch and the left main and the LAD and the mid LAD lesion looks exactly the similar. And we did, again, the pressure wire IFR was done, which looks 0.92, and patient remains asymptomatic with no angina. So we have left we have deferred the procedure. So my take-home message is that the bifurcation with large side branch, mainly in the left main setting, and the large, when it's 2.5 or more, are common. And historical studies have shown that side branch restenosis at the ostium with provisional stenting is high, with high MACE events, and also even with two-stent strategies in these cases. SLR or drug-coated balloons have shown feasibility and improved outcomes in small vessel, ISR, and side branch lesions. And this is a novel technology for potentially improved outcomes in complex bifurcation lesions with used either as a primary or as a hybrid approach, as I've used in my case. Now, provisional main vessel stenting and DCB to side branch is effective treatment strategy for simplicity and better outcomes, because most of the operators will do a kissing balloon here in this case. And if the kissing balloon alone is done, there will be very high risk of restenosis at the side branch. And if it is a large side branch, I think the alternative option is to use drug-coated balloon to the side branch as a hybrid, and it could be safely crossed. In my experience, I've been using it for last couple of years and for last 12 months with this technology. I've not had any problem with delivering the drug-coated balloon through the stent strut after opening up the stent struts and using it after the main vessel stenting. We probably need randomized trials with side branch drug-coated balloon in large side branch, mainly in the left main setting, compared to either provisional or two stent strategies going forward.
Okay.
Thank you.
Thank you very much. Thank you.
May I ask one question? Yeah. So I'm interested in the position of the kissing balloons, because you kissed with the deb, and so how far do you go back into the left main? Do you try to snuggle so that the drug-eluting balloon stays exactly in the circumflex and you don't get the double drug dose with the stent in the left main? What's your strategy?
Yeah, so those are the valid points. And we also thought about, there is no bench study done to see, but there was a small study done to see that the one issue is the crossing of drug-coated balloon through the stent, so whether it can shear off some of the drugs or the thing on the balloon. But they have shown that there is no shearing off of the drug when you cross through the stent strut if the stent struts are well open before. And when we put drug-coated balloon, we try to put the dot into the main vessel. So we keep minimum possible protrusion into the left main stem when we put the drug-coated balloon for 60 seconds. And once it is done, then we pull back the balloon about half a length and then do the kissing balloon. I've been doing it with the same balloon, obviously, just for the simple reason that we don't want to cause any dissection at the ostium and we don't want to keep it undilated. And we have not had any major problems so far.
Okay, so yeah, if there are not other comments, we will go further with Antonio Colombo's talk and his takeaway messages, which we're all looking for. Thank you, Antonio.
So I think you heard most of the strategy that has been suggested. I try to summarize, and this is an old slide that I keep on presenting, but this is a bioresorbable scaffold. But this illustrates the concept of positive remodeling and can only be achieved if you don't have a permanent device. And besides the bioresorbable scaffold, the drug-coated balloon are such a device. You see the mean lumen post-index procedure was 4.9, and after 32 months became 7.3. And this positive remodeling is not a constant event. Even with drug-coated balloon, it may occur maybe 30 to 40% of the times, but with the stents, it occurs 0% of the time. And this is also the pulsatility. So why we can afford not implanting a stent in every lesion? We couldn't say this 5 years ago. Now we have tools to obtain optimal lesion dilatation, rotablation, orbital atherectomy, lithotripsy, laser with contrast, cutting and scoring balloon, very high pressure balloon. We can really get, I don't think lesion preparation, lesion dilatation, because we basically, preparation, it means to implant a stent. So we can really do something that a few years ago was not so easy to be done. We have imaging and physiologic tool to evaluate the result, not only angiography. And I think the term dissection is a yes and no terminology. If you go back to the old classification, there is a type of dissection, type A, B, etc. So a very tiny extraluminal dissection is tolerated and sometimes is what you need to achieve in order to dilate the lesion. So I don't think we should be afraid if you see some dissection of the vessel. In addition, we have optimal antiplatelet therapy, we have dual antiplatelet therapy. So we have a way to do better angioplasty. Unfortunately, many young interventionists have never been trained to do angioplasty. They only trained to do stent implantation. As a matter of fact, they say, I failed to implant a stent. A key element in this strategy is to limit stent length, is to tolerate a dissection. I mean, tolerate doesn't mean not to treat a dissection when it needs to be treated, but to be not dogmatic and treat with a stent any type of dye staining that looks at dissection. In the old time, this is a paper we published in JACC in 2015 about spot stenting, and we did a lot of spot stenting. Unfortunately, many people contradicted us and told us that you should stent every spot. But at that time, a dissection was not stenting if the IVUS measurement of the true lumen at the dissection site was at least 50% of the vessel cross-sectional area, or the minimal lumen cross-sectional area was 70 to 80% of the vessel cross-sectional area. And we really did not have occlusions, and we were working with thick strut stents, not very new stents. These are the type of dissections that I believe you should not tolerate. You see on the left side there is an LED with dissection. As a matter of fact, a physiologic assessment shows that these dissections are not are flow limiting. But with further balloon dilatation, you don't tackle the dissection. It's very difficult to tackle the dissection. Sometimes it happens, but what you do is further balloon dilatation. You make the true lumen larger, and the dissection gets smaller as far as occupying the vessel architecture. And as a matter of fact, the physiologic assessment becomes more benign with an FFR of 87. And this is the immediate result in two projections, and this is a follow-up after 1 year. This is, of course, we did a drug-coated balloon after lesion preparation, but it's really pleasing when you see this anatomy preserved. And of course, one image is not sufficient, but I hope next year we will be able to present data. I think I already showed this slide many times, but Dr. Leone will present, I believe, tomorrow these data. And we did the complex lesions, 80% LED with various devices, I mean 6% almost rotablation. So we are not dealing with a straightforward simple lesion, a shock wave 5.8. We had to do bailout stenting in about 5% of the cases, and in 10-11% we did some kind of stenting associated. We used various devices as far as drug-coated balloons, and we measured PDPA. Why we measure PDPA? Because almost all of these lesions had a dissection. So we wanted to be absolutely confident that we were not putting this patient at danger. And this is after lesion preparation of DCB. We don't know what is a magic PDPA number. We assume that it is about 10, but we need some IVUS guided study. So to summarize, this is my last slides, how to prepare a lesion before DCB. predilate and pretreat the lesion as you plan to stent. Some people are more conservative, and I don't know if the strategies I propose is the right one. This is the strategy we utilize. We do optimal lesion preparation, then we do angiography. If the angiography shows a good result, we go for DCB and we don't waste time. If you have a questionable result, we evaluate the lesion with whatever device you have. If you like IVUS, you do IVUS, OCT, FFR, PDA. If the lesion evaluation tells you that it's just an angiographic turmoil, but the lumen is okay, you do DCB. If the non-angio evaluation tells you there is something not acceptable, you do another dilatation, most of the time with a bigger balloon, because whatever happens, you always have a stent in your laboratory. If after the second dilatation the situation improves, you do DCB, otherwise you implant a stent. With this strategy, we end up implanting a stent maybe 10-15% of the time. We try not to use this strategy when you're dealing with a short lesion located in a 3.5 vessel. I think at this moment we are still a little bit conservative in that respect. Thank you for your attention.
So one important question, Antonio, is which means the strategy is almost based on the, let's say, also primary result after angioplasty when you have any kind of recoil. You don't believe that there can be positive remodeling future as well? Or because you said whenever there is after the primary angioplasty, you see that there is a residual stenosis, it's not the optimal, let's say, primary result on imaging. How do you define it?
In imaging, we need a lumen which is, as I said, at least 70% of the cross-sectional area of the balloon we utilize. If you use a 3 millimeter balloon, that is a common balloon, you expect a cross-sectional area if the balloon does a stent implantation of about 7.5, 8. We like to have a lumen cross-sectional area about 5.5. So okay. It's about 60-70%. If there is a dissection, the presence of a dissection is tolerable if the true lumen cross-sectional area is large enough, because it's like competing forces. The dissection will be too weak to compete with the true lumen, which is large enough. And with time, the true lumen will win over the dissection. This is something that I did in the last 40 years.
Yeah. Yeah.
Just a brief question, Antonio. So those patients where you have dissection after the procedure is finished, how many percentage may have to come back to the left due to acute closure after the procedure is done?
I'm sorry to say, because I almost never say that, but so far, nobody.
So that's an important point as well.
And the other point I encourage, if you have some dissection, do not keep on injecting dye, especially now with the power injector. You need a weak assistant.
Yes.
Yeah. So yeah, one very last question because we're out of time.
2 points. One is when you're inflating a long drug-eluting balloon, we go slowly. I mean, I go slowly till 6 or 8 is being achieved. Now you count 60 seconds from that point of time or starting from the inflation?
I'm not so rigid about time.
Yeah, you can extend it up to 90 seconds or something
I stay...
And the second question is how much time you should wait after taking out the wire to check finally that...
That's very important. Sometimes if I have to do 2 lesions, I predilate the LAD, I do everything. I leave the wire on the LAD. I don't use drug-eluting balloon on the LAD. I do my job on the circumflex. So I wait 20 minutes, 15 minutes. Maybe I place a stent on the circumflex because every patient wants at least one stent. And then in that period of time, I check if the LAD has recoil. If in 10-15 minutes the LAD has recoil, maybe it's no good. I dilate more, I do something more. But if the LAD has no recoil, and sometimes I leave a pressure wire in the LAD, and it's amazing that I see at the end of the procedure the PDPA is 91, 92, after 10-15 minutes becomes 95, 96.
Antonio, what you're saying actually is that the flow is the most important, right? Because
Yeah,
you use anatomy,
exactly.
but it's the flow, forward flow, that will also keep the dissection open, right?
And it's interesting that I do a lot of procedure with the pressure wire, also to understand myself. And as soon as I finish the dilatation, the PDPA is 91, 89. And then I wait 2 or 3 minutes and goes up. And this, to me, is the most important element. If it goes up, it's good. If it goes down, you do another dilatation or stent.
Very interesting, very interesting. Yeah. So I think we could discuss
Okay.
for hours. Thank you
But
very
these
much.
are all anecdotal, please, don't take
Thank you
it.
very much. It was a great session. Thanks, Antonio.